Good morning, everyone, and welcome back, commissioners. I hope you all enjoy the hot, wet summer. Anyway, it's really nice to see everyone and get started with the business of the commission. I'm Bobby Kaplan, Vice Chair of GIC, and I'll be chairing today's meeting in Chair Valerie Sullivan's absence today. We're joined today by the following commissioners: Designee for A&F, Cassandra Broder; Designee Rebecca Butler for Division of Insurance; Elizabeth Chabot; Adam Chapdelaine; Christy Clenard; Jane Edmonds; Joseph Gentile; Gersino Garand; Patricia Jennings. I believe that, Melissa Murphy Rodriguez, Anna Seneko, and Timothy Sullivan. Absent today, Valerie Sullivan, Chair; Tamara Davis; Edward Toby Choate, and my understanding is that Eileen McEnany will be arriving late. Matt?
Just one additional
Sure.
note that we got late word from Gersino Garand that he's not able to join us today.
Okay. Thank you.
Vice Chair Kaplan, one correction.
Sure.
Commissioner Chapdelaine is not with us today.
Oh, okay. Thank you. Sorry about that.
Those are late breaking developments.
Late breaking news, right?
Yep.
Yes, thanks. All right, Matt.
All right,
we can review the agenda.
Thank you, Madam Vice Chair, and thanks for sitting in for Chair Sullivan this morning. Good morning, commissioners. Welcome. As Bobby said, I hope you enjoyed your summer, and as we all did. While we've also been very busy on some items that we'll bring you up to speed on today. For the agenda, I will touch on a few items in the written executive director's report. We will have a presentation from our colleague Deb Danielson from CTI around our health plan audits. As you know, we audit our plans every other year. Each of our plans gets an audit every other year, so we have a cycle of doing this every fall. We will also circle back with the commission around a bulletin that we intend to issue regarding municipal coverage. This is an issue that we discussed back in the spring and had some suggestions from the commission on how to socialize that and get some feedback, which we've done. And we will close out with a CFO report from Jim Rust. This will be a year-end review closeout report from fiscal year 23. So that's the agenda we have today. I do want to note at the outset two changes to the commission membership. We referenced Adam Chapdelaine a little earlier today. Adam, having been appointed the new executive director of the Massachusetts Municipal Association, which we are very excited about, has stepped down from the commission as all of that sort of happened, and he assumed the job just a few weeks ago. So unfortunately, he's not here for us to thank him for his 5.5 years of service to the commission, but he was an excellent commissioner and will be missed. I also just want to note Christy Clenard, who has joined with us today, will be stepping down from the commission at the end of her current term in October. So this will be, unfortunately, Christy's last meeting with us after 7 years on the commission, during which she's seen many things and contributed a great deal to this work as an extremely thoughtful and engaged commissioner. So Christy, I want to thank you for all of your guidance and wisdom in my time here and before my time here. So thank you for that.
Thank you, Matt. Christy, we will definitely miss you and miss your input. I just want to say it's been a pleasure sort of serving on the commission with you. And I wish you luck in your next endeavors, right? In forthcoming endeavors. So thank you.
Thank you, Bobby, and thank you, Matt. It's been a real honor. I'm very grateful that I've had this opportunity to serve. And I know that all of your work will continue as wonderfully as it has, because you're all so thoughtful and competent and innovative. And so thank you for giving me an opportunity, and I will miss you all.
Christy.
Thank you. We have minutes from our last meeting on June 15th before us for approval, and I will entertain a motion.
So moved. Second.
Thank you. Thanks. Okay, all in favor? Are there any, first of all, any changes? Comments, amendments, nothing. All right. Could we all in favor?
Vice Chair, I need to do a roll
Oh, you
call.
have to, I'm sorry. Yeah. Sorry, Andrew. This is what happens, right? When I chair once a year. Sorry about that.
That's why we're here to help.
All right, Andrew.
Vice Chair Kaplan, how about your motion?
What?
Your vote.
Yes.
Designee Roeder?
Approved.
Designee Butler?
Yes.
Commissioner Shabbat?
Yes, and let me make a note. I keep freezing on my screen, so sometimes you people are coming in and out, and I apologize. And then it reconnects. Don't know why.
Thank you. Commissioner Kleinard?
Aye.
Commissioner Evans?
Aye.
Commissioner Gentile?
Yes.
Commissioner Jennings?
Yes. Commissioner
Murphy Rodriguez?
Yes.
And Commissioner Sinenko?
Yes.
Commissioner Sullivan, I'm sorry, I left you off.
Yes.
The motion passes unanimously.
Andrew. Matt, I'll turn it back to you for your report.
Great, thank you, Madam Vice Chair. Just a few words I'd like to say about the written executive director's report. As you can see, we've had a very productive summer. One item that I'm very excited about and would like to highlight for you all is something that the GIC team and some of our colleagues elsewhere in state government have been working on regarding our members, and something we've been pushing for many years. As you all know, as long as the GIC has been around, those newly hired by the state or one of its other municipal partners have had to wait at least 60 days, sometimes longer, for their insurance benefits to kick in. This, of course, has presented a hardship for many of our newly eligible members, and it's often meant that they've had to pick up COBRA from their prior employer to cover an insurance gap. And unfortunately, some have actually chosen to go without coverage for a brief period. So you may reasonably ask how this can be in Massachusetts, where we really pride ourselves on health insurance coverage, but it is an extremely complex project that not only requires substantial changes to our core data systems, but also 200 plus different payroll systems of the agencies with which we work. Nonetheless, we started about 2 years ago working with our colleagues at ANF, the Human Resources Division, and elsewhere to lay the groundwork for taking this on. In addition, a more recent development is that The fiscal year 24 budget enacted this summer actually directs the GIC to provide eligible employees with benefits on the first of the month after their hire date, or if their hire date is the first of the month on that date. And this requirement goes into effect on July 1st of 2024. So we have a lot of work to do in a relatively brief period of time. So I just wanted to say a few words about this project. We will be applying this change to all benefits in the GIC portfolio, not just health insurance benefits. Initial communications about this upcoming change went out to all stakeholders this week, and we have a commitment to stay in regular contact throughout this process. We are currently in the late stages of an intensive discovery period to really scope this project out, and we will be sharing more details with you and others over the coming year as those details all come together. So this is an exciting change that folks have been asking about at all levels of government and our members, and we're really excited about the impact that this will have for newly hired employees. Secondly, I just want to draw your attention briefly to the HR update in the written report. You'll see we have a large number of staff who were awarded Commonwealth citations for their outstanding work. I want to acknowledge all of those members of our team. It's really it's a distinction to be acknowledged through the Commonwealth citation. I also want to finally acknowledge that we've recently promoted Cameron McBean from a manager in our vendor management unit to director. I suspect all of you are familiar with Cameron as he's presented at many commission meetings over the last few years. He's an outstanding member of the team and always willing to step up whenever it's needed. So I want to acknowledge that and congratulate Cameron. Just quickly note that there's also a comprehensive communications update in the executive director's report. We often get questions about work that we're doing in that space, so we want to continue that as a regular feature of our written report. With that, I am happy to take any questions from the commission about the director's report.
So I just, first of all, I don't know who to congratulate first. Cameron, I'm so excited about this. So congratulations, Cameron. I personally know how hard you work and how deserving you are of this position. But also many, many thanks to Matt and Paul and, everyone on the commission and Andrew for getting this done. This has been years in the making, in the wishing, I should say, of every state employee, all the people that I represent, that Liz Chabot represents, that Joe Gentile, that, Tim Sullivan, like all of us, Jerzino, who represent labor, who represent our employees, to be able to have health insurance immediately upon hire is the best news that we could have gotten. And I know how hard it's been to get here and how hard the next year is going to be, or the next, 10 months, right, of getting this up and running and implemented, including all the communications that have to go out everywhere. This is just amazing. And I want to tell you how much I appreciate personally and in support of all our employees who will be so delighted, and all the future employees. It's a wonderful thing. And I can't thank you enough.
Thank you for that, Bobby. We're really excited about the work.
Great.
Any other questions, comments from the commission on the executive director's report?
Okay, if there were no other questions, Matt, back
Yep.
to you.
We'll go on to the calendar review for the remainder of this calendar year. As you can see, after today's meeting, our October meeting has been canceled, as we sometimes do in a normal year. We will reconvene in November to vote on the plan audit procurement, and also hope to have our colleagues from the Health Policy Commission and the Center for Health Information and Analysis to present their annual cost trends report, which was just released last week. Very good reading for those of you who follow healthcare in Massachusetts, if you get a chance to read it. We are working to finalize details with our colleagues in those two agencies, but our hope and intent is to have them join us in November. As we do every year in December, we will start the rate development process by discussing our preliminary projected aggregate increases for FY25. And we will also have a 2024 tentative meeting schedule for you ready before the end of this calendar year. So those are the months ahead. Happy to take any questions on the calendar before we move on to the business of the day.
Okay, there are no questions.
Seeing none, thank you. On to the next agenda item.
Sorry, sorry.
Oh, no, it's all
Matt.
right. Just waiting for the slide to move.
As long as you're not waiting for me.
Nope. So at this point, I'd like to hand it over to Jim Rust, who will introduce our colleagues from CTI on the plan audit. Jim?
Thank you, Matt. Good morning, commissioners. Good to see you all again. As you may recall, we audit our health plans every 2 years to ensure they are performing their services in accordance with their contractual obligations and industry benchmarks. Claims Technology Incorporated, or CTI, performs these audits for the GIC, and today Deb Danielson from CTI will be presenting their findings. I would also like to recognize the good work Catherine Moore does managing this project with CTI and the audit process in general. I will also note, as will Deb, that this is not the end of the audit process. Following this meeting, CTI and the GIC meets with the plans to follow up on the findings and form a plan for improving performance where necessary. And with that, I will turn it over to Deb to present their findings. Deb?
Good morning. Can everybody hear me?
Yes.
Very good. And I'm assuming I can ask someone to turn the page for me as we move through the presentation. Thank you. Good morning. My name is Deb Danielson. I'm an account manager at Claim Technologies Incorporated. We're located in Des Moines, Iowa, and we're pleased to have represented the GIC's medical claim auditing needs since 2020. Today, I'm going to present results from the audits of Fallon Health, Health New England, and Unicare for fiscal year 2022. I'd like to state that each of the carriers participated willingly, and we do appreciate their cooperation. CTI performed these audits remotely, as most administrators or carriers are still not allowing auditors on site post-COVID-19. The goal of CTI's medical claim audits was to determine whether or not each carrier followed the GIC contract terms, claims were paid according to plan documents, and the provisions in those plan documents were clear and consistent, members were eligible and covered by a GIC plan at the time a service was incurred and paid, and finally, if there were any claim administration, eligibility maintenance systems, or processes that presented improvement opportunities, we noted those as well. Next slide, please. So the first component of our random sample, or our comprehensive audit, is a 200 claim random sample. As the name implies, this is a purely random sample. It's statistically valid with a confidence level of 95%, plus or minus 3% bound, which is very common in the auditing industry. The second component, and not to be confused with the random sample, is a 100% electronic screening and analysis, followed by a targeted sample of 150 claims. In this component, we screen all claims paid or denied during the audit period. This is done via our proprietary software we call ESAS or ESAS. We have a number of predefined algorithms in place to make sure operationally that each of your carriers is performing its duties soundly by containing costs on behalf of the GIC and ensuring each has the basic operational procedures in place for things such as preventing duplicate claim payments and managing high-cost claims. In addition to those predefined algorithms, we also take each of your plans and custom code the limitations, exclusions, cost share like deductibles, copay, coinsurance, out-of-pocket maximums, and then we run 100% of the claims for the audit period through all of these proprietary and GIC-specific algorithms, and anything that breaks a rule presents itself on a report for our CTI auditor to review and select, or target, if you will, 150 claims to test. Our auditors know that if they see a $7,000 duplicate claim and a $70 duplicate claim, that they always pick the $7,000 dupe. Our goal is to target and select the samples with the most material impact for the GIC. The third component of our comprehensive audit is an extensive operational review questionnaire, which also includes management interviews with each of the operational areas for each of the carriers. And finally, the fourth component, we look over your plan documents and member handbooks to make sure the GIC plans are clear, they are consistent, and if there are any silent or ambiguous provisions, we will note those. Next slide, please. The audit period for these three carriers, Fallon, HNE, and Unicare, was fiscal year 2022. So any claim incurred July 1, 2021 through June 30, 2022, and paid through December 31, 2022, was included in the universe of claims. On this slide, you can see for each of the carriers, the various plans we audited, the amount paid by each of the carriers, the total number of claims paid, or processed, meaning paid, denied, or adjusted. And then a final measure reported on this slide is median claim turnaround. This is defined as the number of calendar days required to process a claim from the date the claim was received by the carrier to the date a payment, denial, or additional information request was processed. You can see on this slide that Fallon had the longest turnaround time at 21 days. HNE processed the GIC claims with a 7-day turnaround time, and Unicare had the shortest turnaround time of 2 days. Ideally, CTI would like to see turnaround time somewhere between 5 and 10 days, and we would caution that while faster might seem better, it can also translate to unintended errors. Next slide, please. So this slide summarizes the random sample audit results for each of the GIC's carriers. Some of you may recall seeing this slide in past years because all we do at CTI are claim audits. We do so many audits each year that we can benchmark your carrier's performance by breaking down our last 100 audits into quartiles, with 25 administrator audits per quartile. The median on this slide represents the point at which 50 audits fall above and 50 audits fall below. This slide shows you that both Fallon and Unicare's performance put them below the median in the first or lowest performing quartile for all three key performance metrics: financial accuracy, accurate payment frequency, and accurate processing frequency. H&E's results, on the other hand, were above the median, with financial accuracy falling in the fourth or highest quartile, and the accurate payment and accurate processing frequency falling in the third quartile. I'd like to remind everyone before moving into individual carrier results that our audits come with 8 hours of post-audit follow-up per carrier for a total of 24 hours. Now that results are being presented to the Commission, we will be moving into post-audit action planning phase, creating and sharing a post-audit action plan with Catherine and each of the carriers to make these results actionable in an effort to get all carrier results above the median going forward. I want to make it clear that has not happened yet, but as Jim mentioned, we will be planning that following today's presentation. Next slide, please. Fallon's random sample audit included 200 claims, and it had a financial accuracy rate of 97.25%. This equates to a 2.75% error rate. There were 20 claims identified with payment errors totaling $5,745.11 in underpayments and $34,202.26 in overpayments. 14 of those 20 errors were adjudicated automatically by the system without any human intervention, and the remaining 6 errors were processed manually. Now, anytime we see errors that were auto-adjudicated or processed without any human intervention as part of the random sample, we know that there are more claims that were affected as a result of that incorrect system configuration. So we always work with the carrier to ask that they perform a root cause analysis to determine how the error was made and the steps necessary to correct the systemic error. Finally, because we know there are more than just those 14 identified errors that occurred across the entire universe of claims, we ask that each carrier pull impact reports to identify all of the claims that were incorrectly processed based on the finding, not just those that were identified through the random sample. 100% electronic screening followed by targeted sampling. The categories for Fallon that presented the greatest improvement opportunity were incorrect copayment on urgent care, emergency room visits, primary care physicians, and specialists. Fallon also incorrectly applied deductibles and copays to preventive services, which should have been paid at 100% with no cost share to the member. And again, as I explained earlier, each of these categories will be addressed as part of the post-audit action planning process. Next slide, please. H&E's random sample audit again had 200 claims, and they had a financial accuracy rate of 99.76%, or a 0.24% error rate. This was the best financial accuracy rate of the 3 carriers and put H&E solidly above the median in all performance categories. We found 4 claims with payment errors, totaling $2,090 in underpayments and $160 in overpayments. All 4 of these errors were adjudicated manually. For the 100% electronic screening with targeted sampling, the categories that presented the greatest improvement opportunities were payment of duplicate claims, payment for repeat genetic testing and excessive drug screenings, and deductibles that were incorrectly applied to preventive services. Next slide, please. Unicare's financial accuracy rate on the 200 claim sample was 97.22%, equaling a 2.7% error rate. There were 11 claims with payment errors totaling $21,026.51 in underpayments and $4,666.82 in overpayments. 4 of the 11 errors were adjudicated automatically by the system without any human intervention, and the remaining 7 were manually adjudicated. As I previously mentioned, for auto-adjudicated claims, we will work with Unicare to correct errors and remediate as required. Our findings during our 100% electronic screening with targeted sampling identified a number of categories requiring improvement for Unicare, such as payment of duplicate claims, payment of excluded services for resident under physician direction, investigational or experimental services, and cosmetic procedures. Next slide, please. We also found instances in which Unicare did not pay for specialty medications in accordance with the GIC contract, instances in which they made large payments to members without confirmation of medical necessity, instances in which they did not conduct high-dollar claimant reviews or investigate subrogation or right of recovery from a third party, and finally, inaccurate application of member cost share to claims that were preventive in nature. As I explained earlier, each of these categories will be addressed as part of that post-audit action planning process. Next slide, please. CTI's recommendation for the GIC for each of the three carriers includes meeting with the carriers to discuss findings, focusing on improving the carrier's financial accuracy, accurate payment frequency, and accurate processing frequency as needed. For systemic errors, carriers should run impact reports to identify and adjust affected claims as directed by the GIC. We also recommend that carriers conduct a focused analysis of errors identified through ESAS to determine if overpayment recovery or system improvements are possible. CTI can provide your administrators with claim details to use in this analysis. The third recommendation would be to review the results of eligibility screening with HNE and Unicare to determine if claims were paid for ineligible claimants, and if so, perform causal analysis to identify workflow and or system improvements to help eliminate paying claims for ineligible claimants going forward. Next slide, please. Recommendation number 4 would be to require both HNE to seek approval before settling subrogation cases where recovery is less than defined amounts. For example, when a settlement is less than 50% for any subrogation lien of more than $100,000. Recommendation number 5 would be to reach out to Fallon and HNE to ensure the GIC has been credited for missed performance guarantees for fiscal year 2022. And finally, number 6, the GIC should discuss its limitation of coverage of nutritional counseling with HNE, as its administration was inconsistent with member handbooks. Next slide, please. The remaining 3 recommendations are for Unicare. CTI would recommend that Unicare analyze whether its mean turnaround time of 2 days is too fast, contributing to its 2.78% financial accuracy error rate. We would also recommend that the GIC request Unicare perform a focused review of its appeals handling process to determine why some appeals took longer than 30 days to process. And finally, the last recommendation for Unicare, per the terms of fiscal year 19 to 23 contract with the GIC, we note that while Unicare received rebates for specialty drugs under the medical benefits, it did not pass any of those rebates on to the GIC. It's my understanding, however, that the new contract recently signed does contain this provision, and rebates will be credited to the GIC moving forward. Next slide, please. That brings me to the end of my presentation. I know I've provided you with a lot of information on your 3 carriers in a very short amount of time. I want to thank the Commission again for the opportunity to represent the GIC and its auditing needs. And if there is any questions, I'd be happy to answer.
So I have a question though. This is really amazing data, I would say, Deb. I really appreciate this, but regarding sort of like the follow-up, like how will we know that these issues have been resolved, or whether or not Unicare, sort of extends their claim turnaround time, or, is the error, it seems the error rate is directly caused by the the sort of short period, the 2-day turnaround time. So I'm very curious about that. Or for instance, HNE and their nutritional counseling, like how do we know that's resolved? Or is there going to be, welcome Eileen, by the way. I just noticed that you arrived, welcome. So I'm very curious about that. Like how will we know what's done? If you could sort of, you know, speak.
I can
that.
speak to that, Deb, if you like.
Okay, sure.
Yeah.
Whoever,
So,
thank you, Jim.
Feel free, Deb, to weigh in as well on your process. But I can say that we've already talked with Unicare briefly yesterday to go over this presentation, to let them know what was in it and to hear their impressions and get kind of a first round of feedback from them in anticipation of CTI and the GIC meeting with them to go through each of these findings. So we're already engaged. Deb and the CTI team will do their post-audit follow-up, and there'll be a formal close of the audit once, you know, Unicare, CTI, and the GIC have agreed that either a plan to correct these things is in place, or maybe in some cases where Unicare is able to address findings, and we may change the finding. But Deb, I don't know if you want to add to that, but that's generally how we do it. I'm characterizing that right.
Yes, Jim. What will happen technically is that we will put together a post-audit action plan and meet with the GIC, Catherine, and those plans, talk through each of the things that we have recommended here, and put together a timeline of when actions need to be completed by, or understand how long an action may take the administrator or carrier, say Unicare, to complete. They'll have feedback from the GIC. The GIC will have input on what items they want them to pursue, what recoveries they may want them to make, which ones they may choose not to because it might negatively impact a member. And so I will spend a number of hours with Catherine and her team going back and forth with the administrators to take care of each of these items prior to, as Jim said, kind of closing the audit and calling it complete.
And one of the things that's great of having CTI on their second cycle now is, as we saw from this audit to the last audit, improvements in the things that were found last time, right? And when we do the next audit, hopefully that's the case again. And if for some reason there were findings that CTI, GIC, and the plan did not agree on, and we really thought were material, we would be back in front of the commission to let you know, give you that update. So,
Thank you very much. Does anyone have any?
I see Eileen has her hand up.
Yeah. I do. Thank you. Thanks, Deb, for the presentation. I have a question about what are industry norms with respect to the financial accuracy error rate, because I guess ultimately to me, it seems like we would want to encourage the timely paying of claims. And so I think 2 days seems like, you know, something that maybe the plan should strive for. And I guess I'm just wondering, in my uneducated, I guess, assumption, it doesn't seem like 2.78 is a super high inaccurate rate. And so I just love some better context for that.
Sure. A couple of things regarding turnaround time. With automated and systemic processing of claims, turnaround time has lowered very dramatically in the last, say, 10 years across the industry. But we also have claims that require coordination of benefits and medical review. And those types of claims take a little bit longer. And so that moves that turnaround time up. So anything that is manually intervened with, any claim that is manually intervened with, allows the administrator, if you will, to take some additional time to look at it. So it is hard to tie actual results to the quickness or the frequency with which they turn claims around. The second item that you talked about, the 2.7% error rate, if you think about the total spend for the GIC, what is 2.7% of that? And so that would translate to millions of dollars. And while 2.7% doesn't seem like a lot, when you add that up across all of your spend for healthcare from, say, the Unicare plan, there is certainly room for improvement there. I'm not sure if you were with us when I was going through the slide that showed where the median benchmark for CTI's last 100 audits were. So the way that we benchmark is, and I went through this earlier, so I apologize to everyone. We benchmark on the last 100 audits that we've performed, and we put your carrier's performance a measure against that. And Unicare and Fallon fell in the first quartile, meaning their performance was equal to the lowest 25 audits we have conducted, the lowest 25 audits of the last 100 audits we've conducted, where HNE was in the highest 50 or 25 audits that we have conducted. Does that add some perspective?
Yeah, I mean, I guess I understand that 2.78% of a big number is a big number, right? But I guess I'm just trying to understand, is a percentage like is that it doesn't seem high to me. I'm not suggesting there isn't room for improvement. I'm just wondering like what an industry norm is. I mean, I liken it to polling, right? They typically will say the margin of error rate of 3, 4, 5%. I'm just wondering what is the typical margin of error?
Unfortunately, in the auditing industry for medical plans, there really is not a set standard, which is why CTI, because we have over 30 years of experience and we conduct so many audits, we are comfortable benchmarking your administrator's performance against the last 100 we've done. And we audit all of the larger plans, all the BUCAs. We audit a number of regional plans, such as that we do for the GIC. And if you think about your performance guarantees that your administrators are willing to give you, if they say that they can guarantee a 98.5% performance rate, then they understand that they are likely to have 1.5% of claims processed inaccurately. And that is not an unusual amount. What we're saying here is that should the plan improve by 2.7%, it would be at the very top of our benchmarking. Does that answer your question, Eileen?
It provides some clarification. Thank you.
Thank you.
Commissioner Edmonds, I saw that you have your hand raised.
I guess I appreciate the commissioner's questioning, because I guess I was grappling with the same thought, that it sounds like the timeliness of Unicare's response is ideal. But I guess my questions are two-part. How do you have confidence that it's the time that the errors are produced because of the quick turnaround time? And secondly, I noticed that some of the errors are corrected automatically, but that the majority seem to be corrected manually. What kind of timeline is involved in making those corrections?
I can say that the correction process for each administrator is going to be different based on the type of error. And yes, all administrators have an internal audit process that they put in place that allows them to catch some of the errors that occur, and they will be automatically corrected. Our job is to find those errors that they don't recognize through their automatic audit or internal auditing process, and helped to determine why those errors occurred and make sure that they don't happen going forward.
I guess what is really, how do you know that it's the timeline that the errors are produced as a result of the quick turnaround, the timeline itself? How do you know that the errors are not created by some other action or forgive me, but I need to be educated on this. I'm not Understanding conclusion.
Honestly, we don't know 100% for sure, and that's why we recommend that they analyze the turnaround time, is to see if that could be a contributing factor.
Oh, I think the presentation suggests that it was the timeline that was producing the errors. That's what I
Yeah.
thought. Really,
Well, it says, yeah, it says here that Unicare should analyze whether its mean and median turnaround time of 2 days is too fast, contributing to its financial accuracy error rate. We don't know 100% that that is what caused the 2.7%. I'm sure there are likely a number of different reasons for those errors to have occurred. In fact, I know there were a number of different reasons for those errors to have occurred. And certainly it was not all due to the timing of the turnaround of claims.
You're on mute, Jane, if
Jane.
you're speaking to us. Sorry.
sorry. I appreciate that. It's just that I was confused. I thought earlier that what you were presenting was that the turnaround time caused the errors.
I think it was my question actually about that, because when I looked at the slide showing the benchmarks and that Fallon's accuracy rate was the lowest, and their, you know, turnaround time was fell within the, I guess, recommended. Isn't that what you said, Deb? The recommended sort of turnaround of
Fallon's
seven-
turnaround, yes, Fallon's turnaround was actually 21 days. and
not
that
Fallon, HNE, sorry.
is right around 7 days.
Right, and you said that that fell within the sort of, I guess, recommended turnaround time, and that,
Yes.
so I made that sort of assumption. That was my, you know, sort of connecting the dots, that, you know, sort of based on that, it seemed to me that 2 days, even though that might be great for the claimant, right? 2-day turnaround time, I just sort of, you know, made that assumption that that was at least one of the likely causes for the high, you know, it's considered, I guess, a higher, or at least compared to the other two, a higher, you know, error rate, financial error rate, that was accuracy error rate. So that was probably resulting from my question, Jane. I might have, you know, confused everybody by saying that. That was my thinking. So I apologize for, you know, for that.
I think Jim wanted to chime in. Go ahead, Jim.
No, well, I wanted to, I don't have any answer to the question, but as just, when you do read the findings, it's the first impression I know we had, and we talked to particularly Unicare, and yesterday was a similar thing, and that's the kind of thing that we'll be drilling down with Unicare to understand better that that's not the case. And I don't think it is the case, but we want to understand why it's not the case, right? And I think both the post follow-up and then outside of the audit process, our weekly Unicare meetings that we have with Cameron Janine and the vendor management group will also be talking about that, so we can have a better understanding. So I think we had similar questions. I think we'll get answers to them and a little better understanding because of the work that was done in this audit. You know, but I don't think we can say right now that it's, as Deb said, it's the causation is 1-to-1 there. The speed caused the.
Yeah, the audit, I think, just flags issues based on the analysis that, as Jim is saying, you know, we need to understand, working directly with the carriers, what happened so that we can remediate issues. It flags things for us to go back and look more carefully at.
Thank you. Are there any more questions? I didn't see any more. All right, I'll turn it back to you, Matt.
Great. Thank you, Bobby, and thank you, commissioners, and thank you, Deb, for presenting today and for your work to assist us in this area. Now I want to turn it over to Mike Berry to discuss our municipal bulletin. Mike Berry, of course, our Director of Government Affairs, who also handles our municipal work. Mike.
Thank you, Matt. Good morning, commissioners. Lovely to see you all this morning. I am back following up on a presentation that you received last year regarding a municipal bulletin. Can we go to the first slide, please? Before we get into the bulletin, I just want to just do some table setting just to discuss the entities that this bulletin will apply to. So as you may recall, there are two avenues through which you can join the GIC. One is via Section 19 of Chapter 32B, and that requires 70% approval of the Public Employee Committee. Or you can join through what's generally described as a more management-driven process that's outlined in sections 21 through 23. The GIC has 28 entities of our 46 total 32B entities that have come in via Section 19, and those are the communities that this municipal bulletin will apply to. So next slide, please. Currently, the communities that are under Section 19 PEC agreements have more restrictions on what they can do compared to the communities in sections 21 through 23. So we just have an example here, a very nice bucket graphic. So credit to Leslie Montero for this. For example, the only way contribution ratios can be differentiated is by plan type, but they all have to be the same. So if you have plans that are PPOs, all PPOs would have to be 80-20 if that was the split. All HMOs would have to be 75-25, and all POSs would have to be 60-40. Communities that are in sections 21 through 23 can have different contribution ratios by each plan. So again, just want to reiterate that some communities that are Section 19 communities, they might have a 75-25 split for all GIC products. However, the only way you can differentiate them is by having these buckets and having all PPOs would be the same, or all HMOs or all POSs be the same. So what this sort of status quo has been in effect since 2008. And over the last several years, we've received outreach from municipal consultants, from communities that have brought questions with regard to what Section 19 PEC agreements can be. And so that is what prompted myself and our general counsel, Andrew Stern, to start looking at this over the last few years. So next slide, please. So this administrative bulletin, one of the things we wanted to make clear is it's a very narrow thing that this municipal bulletin does. So all it does is it rescinds previous guidance and provides an updated set of guidelines that removes the restriction that allows that only allows differentiated ratios by plan type. Really what this does is it just gives PEC, which stands for Public Employee Committee, entities additional flexibility to perhaps tailor plan contribution ratios that may incentivize enrollment in lower cost or higher value plans. One of the other things we wanted to point out was what this bulletin does not allow. So this doesn't allow differentiated contribution ratios by other factors such as date of hire or retirement, bargaining unit, or type of coverage elected. For example, charging family plans a higher contribution ratio than an individual plan. Next slide, please. One of the things that came out when we brought this before the commission last year was you asked us to socialize this with our stakeholders. And so what we did was we put together a small little focus group that was comprised of 3 HR directors, 1 town administrator, and 1 benefits coordinator, all from GIC communities. And we had 1 Zoom meeting with them in the spring and brought this before them to discuss what the intent was, answer their questions. And there was certainly a number of questions that we answered. And generally what we wanted to do was we wanted to make sure that this bulletin as read would be easily understood by PEC members, by consultants, by town administrators. And the feedback we received from our initial bulletin pointed out that there was some confusion and that there was certainly a bevy of technical language that we were able to streamline. And as a result, I think we came up with a significantly improved bulletin that I think will communicate exactly what we wanted to and eliminate any areas of ambiguity. So I also want to thank, before I conclude, Commissioner Murphy-Rodriguez for her participation and tremendous feedback, as well as former Commissioner Chapdelaine, who was also involved in this process, that really helped us, I think, come out with a much improved product. So with that, I'd be happy to answer any questions from the commission.
While folks are contemplating asking a question, thank you, Mike, for the presentation and for the work on this with Andrew Stern. We've talked frequently in the commission about how we can make the GIC a more attractive option to municipalities. And this is one of the areas where we have gotten some feedback from municipalities, as Mike said, over the years, to provide them some additional flexibility. So I would put this all into the category of us trying to make some progress in that area, that the commission and we, share that important priority. So. You can recognize yourself, Bobby. You're the chair today, so take yourself off mute. There you go. You're on mute, Bobby, if you want to talk.
Sorry about that. So Mike, thank you for the presentation. So I just want to make sure I understand. So municipalities under section 19, right, they won't have to sort of assign the contribution rates by plan type, right? But they have the flexibility to do so?
Correct. I should also make clear that if communities continue to bucket, that is actually still allowed. What typically you see with communities is that, for example, what used to be called Unicare Basic, now Total Choice, sort of the higher cost plans sometimes would have maybe a split of 60-40. So they would, that indemnity plan, certain communities would say, okay, there's going to be a higher split for that. And perhaps the lower cost HMOs might have a little bit more of a friendly split, 75-25. That was the only way you could differentiate it. You had to sort of keep all the plans, again, bucketed is the best analogy that I can use. What this does now is it says, once the prior bulletin was reviewed, was that there really isn't anything in the statute of Chapter 32B that provides this restriction. And so what we're saying is that public employee committees have the flexibility, if there's a particular plan that they want to incentivize, that they can go ahead and do that. If communities continue the status quo, this bulletin does not alter the validity of current PEC agreements, so it doesn't mean anybody is out of compliance. All this does is it adds one additional tool to Section 19 communities that they can choose to utilize or not as they consider their current and future enrollment in the GIC.
Yeah, thank you for that. I just wanted to make sure that I understood it correctly. So thank you. So this bullet, when is that going to be issued, I guess, or the bulletin?
Sure. I believe our plan was pending the affirmation of the commission. It was planning to be sent out certainly by the end of the month, but probably sometime next week. And we think the timing would also be welcome, given that we do have communities that are in renewal. So, but that would be the expectation.
Thank you. I have another question regarding the, because isn't December or December 1st, the deadline for municipalities
Correct.
to decide whether they're going to renew or, so to your knowledge, are the existing municipalities, is there intention to renew, or do you have a sense that some may drop out? And are there any new municipalities sort of coming into the GIC?
Sure. Well, I did just check the betting line in Las Vegas, and the prevailing wisdom is to bet on another stable year for the GIC municipal portfolio, generally speaking.
And as we've said in past meetings, we routinely get data requests from municipalities. This year is no different in that regard. So,
okay. Well, thank you for that. Does anyone have? I don't see any hands raised. So, Matt, I'll turn it back to you.
Thank you, Madam Chair. We can move on to the next agenda item. I will hand it over to Jim Rust, our exemplary CFO, to report with the CFO report. Jim.
Thank you, Matt. I appreciate it. I'm going to provide a quick update on the close of fiscal year 23. As you know, we don't meet over the summer, and right now we're almost at the end of the first quarter of FY24, which is amazing. But I won't dawdle over these slides too much. This is the payment to each of our vendors for the whole year, so for all 12 months. So the font has gotten really small, but this is informational for folks to see what we pay for both the state side, which is this side here. So these are state funds to each of our vendors, and the next slide, as you know, is the employment payments to each of our vendors. Next slide, please. Next slide, please. And you're all familiar with this slide. This is our yearly spending and the shape that we predicted and how the shape actually worked out. So month to month, Catherine Moore, our budget director, spends a fair amount of time on this, trying to forecast the budget month to month. And we can see we pretty much had the shape that we expected. The spending was a little bit less than what we budgeted, but overall it was a pretty accurate year for the budget process. Next slide, please. This slide, as you all know, I like very much because it shows the enormity of our budget, the over $2 billion budget, and the fact that our variance is very small in between that spending. Not insignificant. I mean, millions of dollars can be used for many different things in the state, but we are a large budget, and although we have a lot of volatility, it is a pretty steady state stream of funding. Next slide, please. And finally, this is the summary for the year. These are all the numbers behind the graph. Overall, we are about $18 million under budget, which is a 0.7% variance of the total budget for the year. And as always at this time of year, I mentioned that there's a lot behind these numbers. These are top line paid claims. It masks a lot of volatility in spending between and among the healthcare and pharmacy vendors. Also, the interplay between price and utilization that drives all this spending. So there's only so much we can take just from the top line paid claims. But that being said, as you know, during the fall, we look at our data warehouse to get a deeper dive on claims, and we also meet with each of the plans in our annual stewardship meetings to get their sense of what was driving the costs and what was driving what care was, how much was utilization, how much was prices, what basically the diagnostic codes look like, and all those kind of things. So we'll be reporting back, as we always do, later this fall on some of our findings there. And moving on to FY24, which is well underway, and as we reported in June, our budget request was approved, so we were fully funded at the levels we requested. These funding levels are sufficient for administration of the agency, so our payroll and all those kind of expenses, IT expenses, those kinds of things. And we also were fully funded at the claims level. As you know, we're self-insured to pay the claims for the benefits for the state employees. And so far through the first quarter of the year, it's a little early to really forecast. I'll be back in November with our first look at the FY24 performance, but it seems as though spending is on target. But again, I caution, this is early in the year. Events can change quickly, as you know, in the healthcare world, and we will keep an eye on it. And with that, I'm happy to answer any questions. All right. Well, if there aren't any questions, thank you very much. And we'll be back in November for FY24 update.
Thanks, Jim. And thank you to Catherine and the rest of your team for all the work that goes into this. He makes it look pretty
I-
easy, but it's a significant amount of work that happens in the background by a very talented team. So thank you for that.
So actually, I do have a question. Because we were like under budget, which I'm sort of surprised because I thought, all the deferred, all the people who might have deferred procedures or whatever during, COVID, certainly during the height of COVID, I thought that we would see more of a, sort of influx of claims.
Mhm.
So do you think that we're likely to see that like for fiscal, this fiscal year for fiscal 24? Is that?
That's a great question, and I should have touched on that. Thanks for bringing it up. So since as the years have gone by now, COVID has been, part of our calculation and our actuarial forecast that we do with our partners at WDW. So I think for FY23, so the year I just reported on, we had quite a bit in our forecast, in our budget requests, funding for those kind of things. So people who had deferred care, who unfortunately then show up at the hospital or the doctor's office very often with a more acute case of whatever it is, they didn't get their screening or something. We've all read about the stories. So, but for budget purposes, we did factor that into the FY23 budget. So I think that's why we didn't end up over budget, because we did factor for it, and it seems like we factored enough for that, but it was a big consideration when we did the FY23 budget. So in FY22, as you may recall, we had that issue, and we had some what we call funding from the state just for that to put down the budget. For FY23 was part of the upfront budget calculation. So it's a great question, and I should have hit on it, but yeah, it's definitely there. It's definitely happening. It's definitely in the numbers. The deferred care, it's happening. Sure.
Thank you for that.
And for FY24, we also see that sustaining, that that is still going on.
Okay, and that's sort of part of the budget calculations, right?
It is, yeah. It's now part of the
for
process.
FY24.
Yeah, it's something that we know is out there, and that we're able to try to forecast as best we can, right? And the plans help us with that. It takes a lot of folks' input.
Thank you.
Thank you.
Thank you, Jim. There is no further questions or comments here. I think we move to the last agenda item, which is just any other business that we may have. But that concludes the presented agenda. And if there is no other business, we could move.
Oh, we could, right? It seems
Yes.
right. I'm supposed to be saying these things, Matt.
That's all right.
I have. Well, I'm basically not meeting expectations regarding my role today. I keep forgetting I'm supposed to be chairing, and instead I'm thinking about questions that I want to ask. So sorry. I'm falling back into my normal role. So I apologize to everyone for that. So if no one has any questions at all, then could we have a motion to adjourn?
So moved.
Thank you, Jane.
Second.
Second. All in favor?
Aye.
Aye.
Bye.
Thank you, everyone. And I hope Valerie is back for our November meeting. Thank you, everyone. And again, Christy, we will miss you very much.
Thank you. Thank you, Bobby.
Right, take care.
You
Thanks,
as well, all of you.
Thank you. Thanks, everyone. Thank you,
Thank
Matt.
you.
Thanks
Bye-bye.
for bearing with
Thank you.
me.
Thanks.
Bye.
Thanks, everyone.
Thank you.
Great job, Bobby.
Thank you. Good job, Bobby.
Thanks.
It's okay. You did great. You did great.
Thank you.